pleasant day to everyone. This is Dr. Kat Bukeli from the Department of Preventive and Community Medicine, and for this session, we shall talk about determinants of health, health targets, and primary health care. So at the end of 1 hour, the students shall be able to discuss the various social determinants of health which contribute to community inequities. They will be able to explain the different building blocks of the health system's framework of the World Health Organization. They will be able to review the salient points of the Philippine Health Agenda of 2023 to 2028. And lastly, they would be able to apply the biopsychosocial approach to primary care management, which means patient-centered, family-focused, community-oriented matrix to health in the context of the Universal Health Care Act of 2019. What is social determinants of health? When you check out the World Health Organization's website, you will see that the social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for health inequities. When we say health inequities, these are the unfair but avoidable differences in health status seen within and between countries. In countries at all levels of income, health and illness follow a social gradient, meaning to say the lower the socio-economic position, the worse the health. Now that we have mentioned inequity, let us first understand what is equity and how it differs with equality. The reality is one gets more than what is needed, while another gets less than what is needed. There is an actual huge disparity between the extremes. There are actually 3 ways to address this reality. First, when there is equality, everyone benefits from the same amount of support. This is considered to be receiving equal treatment, but it actually doesn't fully address the problem. When there is equity, everyone gets the amount of support they need, meaning to say the ones with less are given more support and those with more support are given lesser support. In justice, no support is given, but the barrier is being removed. The following list provides examples of the social determinants of health which can influence health equity in positive and negative ways. We have income and social protection, education, unemployment and job insecurity, work-life conditions, food insecurity, housing, basic amenities and the environment, early childhood development, social inclusion and non-discrimination, structural conflict, and access to affordable health services of decent quality. There are 2 types of determinants. We have the structural determinants, which generate stratification and divisions in society and define individual positions within hierarchies of power, prestige, and access to resources. Examples of which include income, education, occupation, social class, gender, and ethnicity. When we say intermediary determinants, these are factors that directly shape individual health choices and outcomes, and through which structural determinants operate, examples of which are financial circumstances, psychosocial circumstances, behavioral factors, and the health system. The structural determinants are social determinants of health inequities. This includes socioeconomic and political context and the socioeconomic position of the patient. Intermediary determinants are social determinants of health per se, which includes material circumstances such as living and working conditions, food availability, among others, behaviors and biological factors, and psychological factors. So the structural determinants as well as the intermediary determinants together with the health system poses an impact on equity in health and well-being, which in turn affects the structural determinants. Addressing the social determinants of health appropriately is fundamental for improving health and reducing long-standing inequities in health, which requires action by all sectors and civil society. What are health systems? According to the World Health Organization, a health system consists of all the organizations, institutions, resources, and people whose primary purpose is to improve health. This includes efforts to influence determinants of health as well as more direct health improvement activities. The health system delivers preventive, promotive, curative, and rehabilitative interventions through a combination of public health actions and the pyramid of health care facilities that deliver personal health care by both the state and non-state actors. The actions of the health system should be responsive and financially fair while treating people respectably. Like all other systems and organizations, a health system needs staff, funds, information, supplies, transport, communications, and overall guidance and direction in order to function. Thus, strengthening health system means addressing key constraints in each of these areas. WHO recommends supporting and strengthening a health system based on this framework. When a health system is strengthened, you improve the 6 building blocks and manage their interactions in ways that achieve more equitable and sustained improvements across health services and outcomes. These 6 building blocks include service delivery, health workforce, information, medical products, vaccines and technologies, financing, leadership, and governance. People are often considered as the 7th building blocks of the health system. So studies indicate that the WHO health system framework is instrumental in strengthening the overall health system and is used as catalysts for achieving global health targets such as the Sustainable Development Goals. So, unlike other health system strengthening strategies, which are usually disease specific, the WHO health system framework intends to improve the overall health in a responsive, financially fair, and most efficient way. So let us go to the 6 building blocks one by one, starting with good service deliveries. Good service deliveries are those which deliver effective, safe, quality personal and non-personal health interventions to those that need them, when and where needed, with minimum waste of resources. Next, we have a well-performing health force, which is one that works in responsive ways, fair and efficient to achieve the best health outcomes possible given available resources and circumstances. The health workforce includes the main drivers of healthcare system and is essential for the efficient management and operation of the public health system. Next, we have the health information system, which is one that ensures the production, analysis, dissemination, and use of reliable and timely information on health determinants, health systems performance, and health status. Next, we have access to essential medicine. A well-functioning health system ensures equitable access to essential medical products, vaccines, and technologies of assured quality, safety, efficacy, and cost-effectiveness with scientifically sound and cost-effective use. Next, we have a good health financing system which raises adequate funds for health in ways that ensure people can use needed services and are protected from financial catastrophe or impoverishment associated with having to pay for them. And lastly, leadership and governance involved ensuring the existence of policy frameworks combined with effective oversight, coalition building, regulation, attention to system design, and accountability. It ensures that the health authorities take responsibilities for steering the entire health sector. It provides health policies, strategies, and plans that set a clear direction for the health sector. We have mentioned earlier on WHO Health System Framework being catalysts for global targets. So this Millennium Development Goals is one of those global targets. So the MDG of 2000 to 2015 are actually 8 goals with measurable targets and clear deadlines for improving the lives of the world's poorest people. And to meet these goals, to eradicate poverty, leaders of 189 countries signed the historic Millennium Declaration at the United Nations Millennium Summit in 2000. So among the 8 Millennium Developmental Goals, there are 3 health-specific goals: for child health, 2 for maternal health, and 3 for combating HIV/AIDS, malaria, and other diseases. In addition, the goal for reducing poverty includes nutrition targets, which directly impact health, and 3 other goals which address social dimensions critical for improving health, which includes education, gender equality, and environmental sustainability. The Sustainable Development Goals, also known as the Global Goals, were adopted by the United Nations in 2015 as a universal call to action to end poverty, protect the planet, and ensure that by 2030, all people enjoy peace and prosperity. Between 2016 and 2030, the same 195 countries that weighed in on the Millennium Development Goals committed to achieving the UN Sustainable Development Goals. From the 8 goals of the MDGs, the SDGs had 17 goals. The principal health-specific SDG ensures healthy lives and promotes well-being for all at all ages. The short titles of the 17 Sustainable Development Goals are no poverty, zero hunger, good health and well-being, quality education, gender equality, clean water and sanitation, affordable and clean energy, decent work and economic growth, industry, innovation and infrastructure, reduced inequalities, sustainable cities and communities, responsible consumption and production, climate action, life below water, life on land, peace, justice, and strong institutions, and partnerships for the goals. Let us go to Sustainable Development Goal number 3, which is specific to health. This aims to prevent needless suffering from preventable diseases and premature death by focusing on key targets that boost the health of a country's overall population. So how do we do this? We reduce the global maternal mortality rate to less than 70 per 100,000 live births, and preventable deaths of newborn and under 5 children, and end the epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases, as well as combat hepatitis, waterborne diseases, and other communicable diseases. To reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and likewise promote mental health and well-being. To strengthen prevention and treatment of substance abuse, including narcotic abuse and harmful use of alcohol, halve global deaths and injuries from traffic accidents, ensure universal access to sexual and reproductive health care services, including family planning, information, and education, as well as integration of reproductive health into national strategies and programs, and achieve universal health coverage, including financial risk protection, provision for quality essential health care services, and access to safe, effective, quality, and affordable essential medicines and vaccines, and lastly, substantially reduce the number of deaths and illnesses from hazardous chemicals and air, water, and soil pollution and contamination. Within the framework of the Millennium Development Goals and the Sustainable Development Goals, as of 2015, the maternal mortality rate was at 204 Filipino mothers dying per 100,000 live births, which is a far cry from the Millennium Developmental Goal maternal mortality rate target of 52 per 100,000 by 2015, and even more than the maternal mortality rate of 192 per 100,000 live births recorded at baseline in 1990. The infant mortality rate was 20 infants dying per 1,000 live births, just shy of the Millennium Development Goals infant mortality rate of 19. The Philippines could have done better, but neonatal mortality rate, a component of the infant mortality rate, did not go down, the reason being that maternal mortality rate did not improve. As many as 25 new cases of HIV/AIDS were being reported to be diagnosed on a daily basis, and the prevalence of smear-positive pulmonary tuberculosis increased from 256 per 100,000 population in 1990 to 273 per 100,000 population in 2008. The target for 2015 was supposed to be 0. Hence, the Philippine Agenda of 2016 to 2022, which was launched by the Secretary of Health in September of 2016, provided the strategic framework for achieving national health targets. So under the motto, All for Health Towards Health for All, universal health coverage is the platform for health and development in the Philippines during that time. Reducing health inequities is singled out as the most important priority among 3 health guarantees, which is ensuring financial protection for the poorest people, improving health outcomes with no disparities, and building health service delivery networks for more responsiveness. In the Philippine Health Agenda of 2016 to 2022, the health system we aspire for should be equitable and inclusive to all, transparent and accountable, uses resources efficiently, and provides high-quality services. And this is in the light of persistent inequities in health outcomes. Around 2,000 Filipinos die annually due to pregnancy-related complications. A Filipino child born to the poorest family is 3 times more likely to not reach his 5th birthday, and 3 out of 10 children are stunted or chronically malnourished. Aside from this, there is restrictive and impoverishing healthcare costs in the country. Every year, 1.5 million families are pushed to poverty due to healthcare expenditures. Filipinos forgo or delay care due to prohibitive and unpredictable user fees or co-payments. And 4,000 per month healthcare expenses considered catastrophic for single-income families. Here are the top 5 mortal illnesses and estimated cost of treatment as recognized by insurance companies, with the highest expense having just a diagnosis of diabetes at 2.8 million, which is even more than cancer, stroke, and heart disease. In public clinics and government health facilities, due to the volume of indigent patients, there are long wait times. Privacy and confidentiality are taken lightly. Usually they share cubicles or even beds, or are just seated outside even during a big procedure. There is limited autonomy to choose provider because it is the resident trainees that are the ones handling charity cases. There is poor record keeping, especially if manually done. There is less than hygienic restrooms, lacking amenities such as standard operating room, CT scan, MRI, overcrowding due to the density of patients, and under provision of care, usually because of the overwhelming disparity of patient to provider ratio. The Philippine Health Agenda has 3 guarantees to attain the health-related sustainable development targets. It guarantees services for both the well and the sick across all the life stages and triple burden of disease. Across all life stages, from pregnant to newborn to infant to child to adolescent to adults, and to elderly with programs such as the first 1,000 days, reproductive and sexual health, maternal, newborn, and child health, exclusive breastfeeding, food and micronutrient supplementation, immunization, adolescent health, geriatric health, and even health screening, promotion, and information. It also guarantees services for both the well and the sick for the triple burden of disease, which includes communicable diseases, non-communicable diseases, diseases of rapid urbanization, and industrialization. Under communicable diseases, we have most commonly HIV/AIDS, tuberculosis, and dengue fever, among others. Under non-communicable diseases, we have cancer, diabetes mellitus, cardiovascular diseases, obesity, smoking and sedentary lifestyle, and malnutrition. In diseases of rapid urbanization and industrialization, we have mental health concerns, injuries and accidents, substance abuse, pandemics and travel medicine, and consequences of climate change. The second guarantee is the functional network of health facilities through service delivery network. Services are delivered by networks that are fully functional, complete equipment, medicines, and health professionals. A service delivery network that is compliant with clinical practice guidelines, available 24/7 and even during disaster, practicing gatekeeping, located close to the people, such as mobile clinic or subsidized transportation costs, and a service delivery network that is enhanced by telemedicine. The third guarantee is the financial freedom when accessing services through the Universal Health Insurance. Services are financed predominantly by the National Health Insurance Program or the PhilHealth. There are three facets. PhilHealth as the gateway to free, affordable care, which means all Filipinos are members. The formal sector premium is paid through payroll, and the non-formal sector premium is paid through tax subsidy. Next we have simplified PhilHealth rules, wherein there is no balance billing for the poor in basic accommodation. So the no balance billing is actually a policy of the government implemented through PhilHealth, which ensures that qualified members shall not be charged or be forced to spend out of pocket for services that had been rendered to them in government hospitals and selected private hospitals that are PhilHealth accredited. So usually yung qualified members are covered by the no balance billing are the indigents, senior citizens, sponsored members, and those who are classified under the 4Ps or the Pantawid Pamilyang Pilipino Program and the Kasambahay Program. There is also fixed co-payment for the non-basic accommodation. Next, we have PhilHealth as main revenue source for public health care providers. So, expand benefits to cover comprehensive range of services with high support value, and contracting networks of providers within service delivery networks. The national objectives for health of 2017 to 2022 serves as the medium-term roadmap of the Philippines towards achieving universal health care. So here it specifies the objectives, strategies, and targets of the DOH Formula 1 Plus for Health, or the F1 Plus for Health, which was built along the health system pillars of financing, service delivery, regulation, governance, and performance accountability. So this ultimately leads to the three major goals that the Philippine Health Agenda aspired for. Number one, better health outcomes with no major disparity among population groups. Number two, financial risk protection for all, especially the poor. And number three, a responsive health system which makes Filipinos feel respected, valued, and empowered. So, the graph on the right shows that in previous years, the Philippine health outcomes improved gradually, particularly in the average life expectancy and stunting among children. However, other health outcomes such as the maternal mortality rate, the infant mortality rate, and tuberculosis have worsened during the pandemic. So come 2023, we have the National Objectives for Health 2023 to 2028. And this is also a blueprint of the health sector for the medium term in the coming years. With the vision that Filipinos are among the healthiest people in Asia by 2040, the DOH will continue to move towards the attainment of its goal of better health outcomes, stronger health system, and access to all levels of care through intersectoral collaboration and partnerships with various stakeholders. So, the 8-point Action Agenda Initiative echoes a call sa Healthy Pilipinas, bawat buhay mahalaga. The overall direction of the DOH is guided by the 8-point Action Agenda. So, number 1, bawat Pilipino ramdam ang kalusugan, which means mainstream and strengthen the primary healthcare approach, ensuring that every Filipino has access to comprehensive health services without experiencing financial hardship, mirroring UHT. Number 2, ligtas, dekalidad, at mapagkalingang serbisyo. This ensures the provision of high-quality, safe, and people-centered services which include access to affordable medicines across the life stages. Number 3, teknolohiya para sa mabilis na serbisyo. This leverages digital health and technology for efficient and accessible health service delivery. Number 4, handa sa krisis. This ensures a responsive and resilient health system and communities that can effectively prevent, prepare for, respond to, and recover from public health emergencies and crises. Number 5, pag-iwas sa sakit. This addresses determinants of health and improve healthy behaviors through the promotion of health-enabling settings, implementation of healthy public policies, and enhancement of health literacy. Number 6, ginhawa ng isip at damdamin. This enhances Filipinos' well-being and ensure quality mental health services. Number 7, kapakanan at karapatan ng health workers. This prioritizes health workers' welfare and rights and strengthening our health institutions against the threat of pandemics. And lastly, proteksyon sa anumang pandemya. This strengthens health systems and structures to prevent, manage, and recover from disease outbreaks and potential pandemics. In this model, the Department of Health acts as a central hub that coordinates and facilitates actions addressing a spectrum of health-related concerns. So these concerns include individual health, community health, and the welfare and protection of health workers. So this model establishes an orderly framework for the effective implementation of policies and programs and initiatives with the ultimate objective of enhancing health outcomes for Filipinos by the year 2028. So, the 8-point action agenda, as you can see, were organized into 3 major categories. So, number 1, para sa bawat Pilipino, that will prioritize optimal health for every Filipino through the establishing provider networks, ensuring provision of safe, high-quality, and patient-centered services, employing modern technology for efficient delivery. Number 2, para sa bawat komunidad, focusing on empowering communities by promoting health, addressing health determinants, fostering mental well-being, and enhancing crisis readiness to ensure community resilience. Lastly, para sa bawat health worker at institution, that will give emphasis on healthcare workers' well-being, rights, and fortifying health institutions against pandemics. As mentioned earlier, the national objectives for health have served as medium-term roadmap for the country towards achieving universal health care. So I know you know universal health care by heart, that in February 2019, the Philippines' first universal health care bill was signed into law by President Duterte. So its objectives was primarily to progressively realize universal health care through systemic approach and clear role delineation of the stakeholders. And of course, to ensure equitable access to quality and affordable health care and protection against financial risk. The UHC have 3 coverages. First is the population coverage, or the automatic inclusion of every Filipino citizen into the national health insurance. Next, we have the service coverage. There is immediate eligibility and access to population-based and individual-based health services. Lastly, we have financial coverage, under which we have population-based health services, which is funded by national government through the DOH, and it's free at point of service. And the individual-based health services, which is funded primarily through prepayment mechanisms. To further define individual-based health services versus population-based health services, in individual-based health services, this refers to services that can be accessed within a health facility or remotely, that can be definitely traced back to one recipient, has limited effect at a population level, and does not alter the underlying cause of illness. Example of which is ambulatory and inpatient care, medicines, laboratory tests, and procedures, among others. When we say population-based health services, this refers to interventions, for example, health promotion, disease surveillance, and vector control, which have population groups as recipients. So individual-based health services are like the services that you get from your primary care clinics. Population-based health services are the services that focus on primordial and preventive medicine. Actually, you may say that universal health coverage starts with primary care. That is why it is important for us to define two terminologies in UHC. First is primary care, which refers to initial contact that is accessible, continuous, comprehensive, and coordinated care that is available at the time of need, including a range of services for all presenting conditions and the ability to coordinate referrals to other healthcare providers in the healthcare delivery system when necessary. A primary care provider, on the other hand, refers to a healthcare worker with defined competencies who has received certification in primary care as determined by the Department of Health or any health institution that is licensed and certified by the DOH. So currently, it is the Philippine Academy of Family Physicians that has reached out to the DOH in terms of certifying PCPs. So what does the UHC have to say on primary care providers? The DOH and the local government units shall endeavor to provide a healthcare delivery system that shall afford every Filipino a primary care provider. The primary care provider shall act as a navigator, initial and continuing point of contact in the healthcare delivery system, and coordinator of access to higher levels of care, except in emergency or serious cases and when proximity of the facility or services is a concern, but this is subject to the National Health Insurance Program of the Philippines and DOH guidelines. The DOH, the PRC, and the PhilHealth shall promulgate the guidelines on licensing of the primary care providers and the registration of every Filipino to a PCP. In terms of network contracting, there will be back referral system that ensures patients that were referred to specialized care are endorsed back to their assigned PCPs once transition back is possible, and that their PCPs should be informed of the clinical diagnosis and the diagnostics administered. There will be a patient records management system, example, an electronic medical record that ensures patients' charts are accessible by all facilities or providers within the healthcare provider network or among other facilities as necessary. Let us zero in on primary care. As mentioned, it is healthcare that is accessible, comprehensive, coordinated, and continuing. It is provided by physicians specifically trained in comprehensive first contact and continuing care for ill persons or those with an undiagnosed sign, symptom, or health concern. So they see the undifferentiated patient and is not limited by problem or of origin, such as biologic, behavioral, or social organ systems. In addition to diagnosis and treatment of acute and chronic illnesses, primary care includes health promotion, disease prevention, health maintenance, counseling, and patient education in a variety of healthcare settings. such as ambulatory outpatient clinics, inpatient, critical care, long-term care, assisted living facilities, and home care. Primary care is the backbone of the healthcare system and encompasses the following function. It is again the first contact care, serving as a point of entry for the patient into the healthcare system. It includes continuity by virtue of caring for patients in sickness and in health over some period. It is comprehensive care, drawing from all traditional major disciplines for its functional content. It serves a coordinated function for all the healthcare needs of the patient. It assumes continuing responsibility for individual patient follow-up and community health problems. And it is a highly personalized type of care. So how is primary health care different from primary care? So, like we've said, primary care is a model of care that supports first contact, accessible, continuous, comprehensive, and coordinated person-focused care. It is actually a key process in health system that provides services such as promotive, preventive, curative, rehabilitative, and palliative services throughout the individual's life course. Primary health care, on the other hand, is a broader whole of society approach with three components. First, the primary care and essential public health functions as a core of integrated health service. Second, multisectoral policy and action. And lastly, empowered people and communities. So, primary care and primary health care is actually a continuum that may be bridged by two approaches. So you know this, the biopsychosocial approach and the PFC matrix. In 1977, psychiatrist George Engel proposed a biopsychosocial model that included a social and psychological variables as crucial determinants of disease and illness. According to his new framework, the subsystems of the body interact to produce successively more complex biologic systems which are simultaneously affected by social and psychological factors. Understanding a person's response to a disease requires consideration of such interacting factors as the social and cultural environment, the individual's psychological resources, and the biochemistry and genetics of the disorder in the population. As Engels stated, all three levels, biological, psychological, and social, must be taken into account for every healthcare task. The biopsychosocial approach is an interplay of three factors that constitutes a person's well-being. First, we have biologic factors, under which we have genetics, medical history, and environmental factors that affect physiologic functioning. So examples are established risk factors for cancer or cardiovascular disease. Next, we have psychological factors. These are affective, cognitive, and behavioral components such as feelings, beliefs, expectations, personality, coping styles, and health behaviors that contribute to the patient's experience of health and illnesses. Lastly, we have social factors, which are the access to healthcare, quality of available healthcare and social systems, such as dynamics in the family, school, work, church, and government, social values, customs, as well as social support. Here is another approach to holistic health care, the PFC Matrix for Health, or the Patient-Centered, Family-Focused, Community-Oriented Matrix for Health. So the patient-centered care utilizes understanding of the interplay of biomedical, psychosocial factors, and disease in order to implement management that is tailor-fitted to the needs and values of the patient. The family-focused component of the matrix utilizes family assessment to generate assumptions on how the family dynamics affect or facilitate the prescribed management of the patient's disease. Then we have the community-oriented component that enables the family physician to use social determinants of health and health systems as a lens to understand how larger systems support or hinder the provision of care. So we shall briefly go through the PFC matrix as you have already encountered this during your TPC when you were in first year. So under patient care, we have under data the relevant medical history, the physical findings, the context of psychosocial issues attendant to the health condition, including bioethical issues. In the analysis, diagnosis, conclusion, or assumption, under which we have medical diagnosis and the psychosocial diagnosis. For the management intervention, we have comprehensive medical interventions and standards of care, encompassing all levels of primary, secondary, and tertiary care, as well as individual psychosocial interventions such as primary care counselings. For the family-focused care under data, we put their assessment of the family psychodynamics through genogram, family lifeline, family APGAR, and family SCREAM. So you may want to go back to your first year notes to review you. Under analysis, we have family life cycle, the impact of illness on the family, such as illness trajectory, enabling factors and barriers to care, caregiver fatigue, and management intervention. We have family interventions to address both medical and psychosocial issues. For example, including family education and capability building of caregivers to minimize caregiver strain. And lastly, the community-oriented care. Under data, you may put their assessment of the social determinants of health and the building blocks of a healthcare system relevant to the biopsychosocial issues of the medical case. You can put also the epidemiologic data, and under analysis, you may put strengths, weaknesses, opportunities, and threats, or the SWOT analysis of a public health problem. And for the management or intervention, put there any community-oriented primary health care, networking and linkages, and health advocacy and legislations. The PFC matrix was actually very relevant during the COVID-19 pandemic. So, in terms of patient-centered healthcare, there was mass screening in high-risk areas. The diagnoses were done through RT-PCR, free in key hospitals. There were treatment that was free for all. There was family-focused care in terms of practice guidelines on living recommendations for COVID-19 patients and their families, and as well as clinical pathways done by Family Medicine Society for home care. There was also community-oriented programs such as community quarantine, and of course the vaccine rollout. And of course the different health policies and legislations that came out during the COVID-19 pandemic. In summary, we have talked about the social determinants of health, which can influence equity in positive and negative ways. The WHO Health System Framework is instrumental in strengthening the overall health system and is also used as catalysts for achieving global health targets. In terms of targets, we have talked about the Millennium Development Goals, which was replaced by the Sustainable Development Goals and was adopted by our Philippine Health Agenda and National Objectives for Health, which in turn pointed out to the implementation of the universal health care. We also touched on the difference between primary care and primary health care, and that there are approaches that can reach these two, such as the biopsychosocial approach, which is one of the methods to promote patient-centeredness. The BSP approach is a perspective that patients' concern cannot be taken in isolation, but rather both biomedical and psychosocial aspect of patient's predicament may affect the impact of the disease and should be considered by a primary care when planning delivery of care. The patient-centered, family-focused, community-oriented matrix is advocated by primary care physicians, provide holistic and comprehensive care, taking into account the family dynamics and social determinants of health, including the basic building blocks of healthcare. I want to leave you all with this quote. The greatest medicine is to teach people how not to need it. Here are my references. Thank you.